Hello, my name is Mahmoud. I'm one of the neonatal consultants from University Hospital Wisho, and I'm very pleased to be here with you all today for the launch of the new special interest group of neonatal functional hemodynamics and point-of-care ultrasound. So I'm going to start with, I'm going to share my screen. Right, so thanks everyone for joining today. In the next 10 minutes or so, I'm just going to explain why we are forming this special interest group and who we are. So let's start with why NeoFOCUS. So in the last 3 years, we recognized the growing evidence for the use of neonatal hemodynamics and point-of-care ultrasound, the growing interest to learn those skills, and we actually recognized there is a gap which is presented as lack of recognized training framework and accreditation pathway in the country. With regards to evidence, we had the first kind of international evidence-based guidelines on point-of-care ultrasound for critically ill neonates and children that was issued by the ESPNIC group on behalf of the European Society of Pediatric and Neonatal Intensive Care that came up in 2020 and provided a lot of evidence about the use of different modalities of POCUS, including neonatal lung ultrasound, cardiac POCUS, functional echocardiogram, and POCUS for line position, and other indications as well. That was followed by the American Academy of Pediatrics, who issued two important clinical and technical reports, again discussed in details the indications and use of point-of-care ultrasonography in NICU for diagnostic and procedure purposes. They also discussed in the other document what kind of governance framework and how you're going to implement it in neonatal units, and they suggested a sort of framework for practice as well. Other consensus statements came out for the use of POCUS in critical ill neonates or the crashing neonate, and our colleagues Nadia Youssef and her group, and also Yasser Said and his group, they independently issued these two, published these two documents, which are very useful and highly recommended to read. Subsequently, from the hemodynamic point of view, there was very detailed guidelines and recommendations for the use of targeted neonatal echocardiography and the difference between that and the cardiac point-of-care ultrasound. The initial guideline was published in 2011, and then that was updated actually last February. Quite excellent document to read for people who are interested in targeted neonatal hemodynamics. With that, there was also a growing evidence that the use of early hemodynamic screening for extreme preterm infants helped to improve outcome in high-performing centers. This paper was published last year by the group from Iowa in the United States, which demonstrated their fantastic work and how they implemented a very specific program for hemodynamic screening and how that had impacted on improving mortality, morbidity, and excellent outcome. So that was the evidence. Now going to demonstrate there was growing interest actually in using POCUS and functional hemodynamics. So we started conducted a survey in 2021, like end of 2021 to 2022. So we sent a survey for all the neonatal units in the UK, asking a question about the use of neonatal lung ultrasound, and the results were quite interesting because we only found only 6% of the neonatal units were using lung ultrasound. And the interest was quite great with actually, as you can see in the numbers, majority of people wanted to learn the skills from trainees, consultants, NNPs, with different kind of uptake from different levels of units. So that was quite encouraging. A similar survey was conducted in Italy by Yuri Corsini and his group, which showed a really great uptake for the neonatal lung ultrasound in their units. Actually, up to 80% of their units were using it. However, they shared the same problem with us, which is the lack of accredited and recognized training program for standardization of practice. And last week, Almudena and her group published this great survey again across 24 European countries, which involved over 560 neonatal units. And there was very variable uptake from different countries. And they also stated the same problem, that the most major barriers for implementing lung ultrasound in neonatal units was no experience with image interpretation or image acquisition. And that takes us back to the lack of accreditation and lack of national training framework. So Nim and his group in Liverpool, women's, they also conducted a survey for targeting neonatal echocardiography, and the results were quite interesting, that the majority, they want to learn and develop TNA skills. And over half of the trainees, they felt strongly that the formal training program should be considered as a compulsory element for subspecialty training if you want to be a neonatologist. Most of them, they raised interest that they would like to learn the skill. And because of the lack of national training framework and accreditation pathway, particularly for neonatal lung ultrasound, our group published this proposed framework last year. And hopefully that will give us a chance to pave the way for more collaboration at the national level to produce such training guidelines and frameworks. Some of you might have heard about CACTUS, which is acute ultrasound in pediatrics. So our colleagues from pediatric ICU formed a group a few years ago, and they developed a specific training program for acute ultrasound in children, mainly targeted for pediatric ICU practitioners. But they had some kind of overlap with neonates as well. So they produced a nice framework for training accreditation, and they managed to get a recognition from the Royal College as well, which is great. However, the CACTUS is, as I said, mainly directed to pediatric population. So we recognize that we need to work on a more specific targeted framework for our population, which hopefully will be the goal of this group. So as you can see, we recognize there is a big gap, and what we really want to do is to work hand in hand with our colleagues from the neonatal community to bridge this gap. So that will take us to who we are. So we started in 2021 as a small group of interested neonatologists. And then very quickly and very rapidly, we shared our interest with interested colleagues across the country. And what we have now, as you can see, many sites across the country that have joined our group. And they are very enthusiastic colleagues, and we hope together with the wider neonatal community that we can produce, bridge the gap and produce lots of frameworks, training programs, accreditations, and help to improve the outcome of our precious sick babies. We have international collaboration from different countries. And in this timeline, I'm very proud to share what we have achieved so far. So we have weekly meetings, so regular meetings for case presentation and peer review. We also conducted many national, international webinars, had multiple local POCUS workshops and conferences held in multiple trusts. We also last year hosted the first UK International Congress in Glasgow in 2023, which was a huge success. We produced the first framework for practice for lung ultrasound. Also, we developed our website. We'll share the link with the group. And now we are here to work hand in hand with our colleagues to form the special interest group in collaboration with our colleagues from BAPM. So this is a picture of our colleagues who really worked hard in the last 3 years to reach where we are at the moment. And the picture on the right corner is from the first International Congress from last year. We had delegates from 17 countries from all over the world. So some links if you are interested to join the meetings, and we have a YouTube channel with upload all the presentations, and if you want to join us on social media as well. Okay, so with that, I will finish my presentation and I will hand over to my colleague Nim, who is going to talk to you about neonatal hemodynamics.
Great, thank you very much, Mahmood, and good afternoon, everyone. I hope you can see my screen okay. My aim over the next 10 minutes or so is to try and persuade you, if you're not convinced already, that functional echocardiography has a role in neonatal intensive care and is really, I would consider, an essential component of providing high quality neonatal care. So historically, we've tried to practice evidence-based medicine by looking at a population of babies and probably treating them all the same, essentially thinking that they are all the same and will respond in the same way, if you like, a one-size-fits-all approach. Increasingly, we're identifying or trying to identify subgroups of babies within that population, either based on perhaps diagnostic criteria or certain pathophysiological characteristics that allow us to tailor treatment in a better, more nuanced way to provide better care for those babies. But of course, the goal, the holy grail of neonatal medicine is to provide fully individualized care for our babies. And that will be dependent on various demographics, underlying diagnosis, pathophysiology, and perhaps even things like genotype to tailor treatment at an individual level. And the way I see functional echocardiography is helping us move across this screen, down this road from left to right, to improve the care we provide and try and provide more individualized care for babies. And there's an increasing volume of literature out there. There was, as some of you all know, a series of articles about echocardiography in particular, published a few years ago now in Pediatric Research in 2018. And those of you who are interested might want to go and seek out these papers. I think they are a really good resource. But I think we can sort of crystallize the role of echocardiography, at least broadly speaking, in 4 different neonatal conditions that we face not infrequently. So there's the assessment of hypotension and shock. There's the management of hypoxemic respiratory failure. And of course, a subgroup of those babies are going to have persistent pulmonary hypertension of the newborn. Diagnosis and management of PDA, a very controversial subject and something that we could spend a whole afternoon on. and perhaps the management of pulmonary hypertension associated with bronchopulmonary dysplasia, which isn't that well established at the moment, but is increasingly being recognized and treated. And I suppose if there were three questions that we would want functional echocardiography to try and answer in each baby, it would be these. Firstly, when to intervene, what drugs or drugs to use, and perhaps in which order. And finally, how to tailor treatment in terms of escalation, weaning, and or stopping treatment in the most appropriate way for each baby. And I'm going to try and illustrate what I think is the value of functional echocardiography using a case. So this was the story of a baby born at 29 weeks gestation, 990 grams, a baby girl. There was a history of PPROM for 72 hours, but complicated by anhydramnios. There had been time for her mother to receive a full course of antenatal steroids, but there was cord prolapse and the baby had to be delivered as an emergency by cesarean section in the end. And then the early treatment is the sort of thing that you might expect in this baby, delayed cord clamping, early intubation because of poor respiratory failure, and surfactant therapy in the delivery room. The baby was then transferred to the neonatal unit where she received volume guarantee ventilation, but in the context of high ventilatory pressures, we changed the ventilation to high frequency oscillatory ventilation. And then in the first few hours, the two principal problems we were faced with was hypotension. So this was a blood pressure of 37/24, and there was a question of whether we should start some treatment with volume expansion. And this baby was also hypoxemic, so remained low oxygen levels despite being in an inspired oxygen of 100% on high frequency. And the question then was, do we start some nitric? Is this PPHN that we're treating? So we had the facility to do a baseline echocardiogram. And of course, this isn't a talk about how to do an echocardiogram. And I can't take you through all of the images I'm showing you in a great deal of detail, but just to give you a flavor of what you could expect from a functional echocardiogram and what sort of information we would get and how we might use it, I think it would be helpful. So here I'm going to go through these images from left to right, starting with the top three. And what we're seeing here is a well-filled left ventricle, which is contracting poorly. And it's not just the left ventricle. If you look at the middle frame here, the right ventricle is also dilated and contracting poorly. And by interrogating the flow out of the left ventricle, we can make measurements and assessments, calculations of left ventricular output. And this we did this, and it showed low left ventricular output. And then if we move on to the bottom three frames here, on the left-hand side, you can see that this baby has tricuspid regurgitation. And the velocity is 3.5 meters per second, so quite high velocity tricuspid regurgitation. And other features of persistent pulmonary hypertension, you can see here in this middle frame, this is the ductus, and the blue flow indicates pure right to left shunt through the ductus, meaning that the pulmonary pressures are higher than systemic pressures throughout the cardiac cycle. So suprasystemic pulmonary arterial pressure. But while the flow at the ductal level is right to left, here on the right-hand side at the bottom, the flow at atrial level is actually left to right, which is slightly atypical and a slightly unusual feature in classic PPHN. And that really goes with an underlying problem with left ventricular function and raised left ventricular end diastolic pressure and left atrial pressure, which is allowing blood to flow in the opposite way, left to right, to the direction that we might expect it to flow. So this echocardiogram gave us this information that there was a well-filled left ventricle, but both ventricles were working poorly. And that was translated into poor left ventricular output. So 110 mils per kilogram per minute is low, about 150 to 200 is probably what we would like to see. This baby had moderate pulmonary hypertension, I'd say, so systolic pulmonary arterial pressure of 55, but that was clearly suprasystemic. And while there was right to left ductal flow, the flow at atrial level was atypical. It was left to right flow, which is unusual. And how that helped us treat this baby was, firstly, that despite the temptation to give this baby volume expansion, there was no evidence of hypovolemia. And in fact, volume in this situation, in this context, isn't the right thing to do, because you're going to then be overloading the left ventricle, which is already failing. The right treatment here is a drug which has pure inotropic activity and no or minimal vasopressor action. So we chose to use low dose adrenaline, and by low dose I'm meaning something like 30 to 50 nanograms per kilogram per minute, rather than upwards of 100, 200 nanograms, which is usually more, gives a more of a tendency towards vasopressor activity. So we didn't give volume expansion, and we started low dose adrenaline. The temptation also here would have been to use nitric oxide. We know that there was pulmonary hypertension, and we had a setup for PPHN, but nitric oxide would have been contraindicated in the setting of LV dysfunction. So here, if you gave nitric oxide, you would increase pulmonary venous return because of the pulmonary vasodilator effect. And that again would overload the left ventricle at the time when the left ventricle isn't working particularly well. So the priority here should have been, and it was, to improve LV function. And when we re-echoed this maybe 12 hours later and found that the function was better, we were in a position to be able to use nitric oxide at that time. But then we were still faced with a problem, because this baby was still hypoxemic 24 hours later. But interestingly, the hemodynamic phenotype had changed in that period. So here, what we're seeing again from left to right, the top frames, first of all, that now the atrial flow is right to left, which is what you'd expect. The ductal flow here is bidirectional, but I hope you can see here that the diameter of the ductus is much narrower. And this is now a restrictive ductus, which isn't what we found early on. And then this image here is showing, it's a cross-sectional image through the, if you like, a short axis view of the left ventricle, showing a very flat interventricular septum, meaning that the right ventricular pressure here is similar to left ventricular pressure, so raised right ventricular systolic pressure. And not only was right ventricular pressure elevated, we had a dilated IVC. So here we're seeing what is, in effect, increased right atrial pressure. And there was still quite severe tricuspid regurgitation, which was high velocity, suggesting persistently elevated pulmonary arterial pressure, despite this baby being on nitric oxide. And finally, there was evidence of right ventricular systolic dysfunction in the form of TAPSE, which is a marker of RV systolic function. So the TAPSE was low, suggesting systolic dysfunction. So here we're seeing elements of persistent pulmonary hypertension, but also RV dysfunction and a restrictive ductus. And echocardiography in this setting helped us, because the focus then became optimizing pulmonary vasodilation. So we had the baby already on nitric oxide, but here we added in milrinone, which is also another adjunct pulmonary vasodilator. And we switched to using vasopressin to support blood pressure, because vasopressin, as you might expect, is a vasopressor, systemic vasoconstrictor, but also a pulmonary vasodilator. So these were things that we did to try and optimize pulmonary vasodilation. But just as importantly, we also started prostin in this baby, because there was right ventricular dilatation and failure. And by opening up a restrictive ductus, we were able to offload that right ventricle and reduce pressure and the size of that right ventricle. So you can see in these two frames, the upper frame is showing that the ductus has opened up now. There's still bidirectional flow, but a widely patent ductus. And in the lower frame, we have now a rounded interventricular septum, suggesting that right ventricular systolic pressures are now lower than LV pressures, which is what we want to see. So to my mind, functional echocardiography in this case identified which drugs we should be using and in which dose, but equally importantly, which drugs we shouldn't be using, and then helped us to tailor ongoing treatment according to changing hemodynamic phenotype. And there's no way we would have got all of that information on clinical grounds alone. And the problem that we're faced with is, with hypertension and shock, for example, that the tools that we have at the moment are very limited. So we, of course, can measure and continuously monitor sometimes blood pressure, but we know that blood pressure is very poorly correlated with left ventricular output. And if we were looking at tissue perfusion, then the correlation would be even worse. And people have recognized that and created quite complex algorithms, as you can see here. This comes from that series of papers that I mentioned earlier on. And while this is a step in the right direction by separating out systolic and diastolic blood pressures, for example, you can see that this section in the middle, labeled green, marked green, is labeled individualized pathophysiology-based hemodynamic approach. And there's no way we can aim for this level of detail and this level of understanding of the basic hemodynamic pathophysiology without the benefit of functional echocardiography. And similarly with neonatal pulmonary hypertension, it's a very complex condition. And of course, while we recognize that pulmonary vascular resistance is a key component and we focus on pulmonary vasodilators, it's being increasingly recognized that ventricular dysfunction, both right ventricular dysfunction here and left ventricular dysfunction, are key components of this triad. And without ways of assessing ventricular function and hemodynamics, we will never be able to start and tailor treatment in the best possible way. So if I'm suggesting that functional echocardiography is the solution, well, what is the problem that we're trying to address? Well, firstly, we know that measurement of blood pressure and just treating hypertension is far too simplistic an approach, and I hope that most people understand that. And that we're dealing with complex situations which have complex underlying hemodynamics. And it follows that blind treatment, according to some sort of pre-specified protocol, is at best illogical, but at worst potentially harmful. And certainly we're not going to make any inroads in terms of effective management unless we recognize this variation in clinical and physiological phenotype and address it in some way. So I think functional echocardiography offers this. It gives you a comprehensive echo assessment with detailed information about cardiac function and hemodynamics, so we don't have to rely just on blood pressure. We can then tailor treatment according to that underlying pathophysiology, a step towards precision-based medicine. And we then will have the ability to assess the response to treatment and tailor management accordingly. And the goal here is to improve short and long-term clinical outcomes, obviously. And although I haven't mentioned this in any detail, we can also use functional echocardiography to standardize assessments of PDA and decide when PDAs should be treated, hopefully, and in BPD associated pulmonary hypertension. Now, a reasonable question that you might want to ask is, what evidence is there out there that's published as to the value and utility of functional echocardiography? And Mahmood mentioned this paper earlier on. And although it's not perfect evidence, it does point to the potential that functional echocardiography might have. So this was the group in Iowa that looked at a before and after study of two cohorts, where in 2017, 2018, they introduced targeted neonatal echocardiography screening in the first 24 hours of extremely preterm babies. And they backed this up with a very rigid algorithm of how to approach abnormalities when they were discovered on echocardiography. And what they managed to show was, between these two cohorts, or following the introduction of this new screening and treatment methodology, they demonstrated a reduction in death and severe IVH in this vulnerable, extremely preterm population. So there are some publications out there, although they're difficult to produce, showing how effective this might be. So I'm going to stop there and leave you with this, with the first slide that I started with. And I'm going to hand over then to Anne-Marie, who's going to take you through the current recommendations for neonatologists performed echocardiography. Thank you.
Thanks, Nim, for this excellent talk. Anne-Marie, floor is yours.
Thank you. So an absolute pleasure to follow on from Nim and his lovely examples of why neonatologists performed functional echocardiography is important. And it's just, I think, a useful time to talk about current recommendations and most likely future directions for training and accreditation. So a pleasure to move on following Nim and to talk about, I think, really standards for neonatologists performed echocardiography. I hope Nim's lovely presentation has shown you that not only by scanning can we confirm structural abnormality of the newborn's heart, but much more importantly, drill down on functional adaptation. And the benefits are that we can understand the unique newborn hemodynamic transition and recognise pathophysiological phenotypes. And that really allows us to drive precision-based treatment that will hopefully drive improved outcomes in the future. But there are challenges. It's quite an advanced skill, and without the ability to correct any image acquisition of good quality and without the ability to interpret, it risks doing potentially harm to the patient, which could in turn, of course, result in harm to the clinician. So robust training and good governance standards are essential. Ideally, I think the gold standard for governance is accreditation by professional bodies, but currently, certainly within the UK, that doesn't exist. Next slide, Marcus. There is some accreditation and governance for echocardiography in paediatrics in the UK. The most recent group to develop are the CACTUS group, the Children's Acute Ultrasound group, under the auspices of the Paediatric Intensive Care Society and Intensive Care Societies, and approved by the Royal College of Paediatrics. However, cardiac POCUS, which fits as an element of CACTUS training, is quite limited in terms of echocardiographic assessment, really relying on eyeball assessment of function and filling and exclusion of the very uncommon pericardial effusion. So it doesn't really meet the remit and standards of neonatal performed echocardiography. Now, there are our colleagues in PECSIC, paediatricians with expertise in cardiology, who've got a very robust curriculum which sits under the Royal College of Paediatrics and approved by the BCCA. But this is really targeted at paediatricians who are going to be looking at congenital heart disease throughout childhood, and doesn't really focus on the sort of functional assessment that we want neonatologists to develop. Of course, there are colleagues in paediatric cardiology with their own very evolved training programs and joint training board accreditations, but realistically, that's not something neonatologists are going to be able to aspire to or take on. However, they do have their British Society of Echocardiography, which accredits their echo training. And it's an interesting group and organisation to look at. They do robust training courses, have educational packages online, and provide a very robust accreditation programme. It doesn't approve anything for neonatologists and neonatologists looking at functional echocardiography, but they have recently developed guidance with groups such as the ADCO Critical Care Group who want to develop echocardiography. So they are perhaps a group in the UK we could look at using. And although there's been a framework published that I'll come to for neonatologists performing echo in the UK, there isn't any actual robust curriculum or standard or accrediting group for neonatologists. So next slide, please. We're not alone in the UK. Similar problems have evolved around the world, and there have been a number of international developments, including really worldwide recognition that a lack of training programmes and accreditation for neonatologists undertaking echocardiography are problematic. Overall, there have been at least 4 consensus statements in the last decade and a huge number of other associated papers describing possible futures and structures for training programmes. There's been little real agreement. The consensus statements come from the North Americans and Europeans together, followed by both separate statements by the North Americans and the Europeans under the ESPR, as well as a UK statement endorsed by the BCCA and PECSIG. Separate from those consensus statements, other groups around the world have developed their own programmes, such as the Australians and the Canadians, and I'll just touch on one of those briefly. But I think maybe it's worth just moving on to the consensus statements that we have. And next slide, please. The first one of those was a big statement published in 2011. It's a joint statement from North America and European interested groups, but I think you can see from the authorship here that it's a statement that's been delivered by echocardiographers and specialist paediatric cardiologists. There's very little neonatal involvement in this consensus statement, and I think that reflects a lot of the guidance and why it's not been widely adopted. Next slide, please. So if you read the paper published, it's very interesting, it's very technical, and you can learn a lot from it. But nonetheless, they maintain training of neonatologists who want to do echocardiography had to be very much paediatric echo lab based, very technically demanding in the number of scans, really required full-time training in echocardiography, and still sat very much under the overview of cardiologists. And I think for these reasons, apart from a few North American centres, this really didn't gain traction, hasn't been established in the UK, and still no formal accreditation developed. Next slide, please. Interestingly, our Australasian colleagues really eschewed the cardiology route altogether and said, well, no, we're neonatologists and we're interested in studying how we echo and assess neonatal hemodynamics. And they developed their own group under the Australasian Society for Ultrasound Medicine, quite separate from cardiology. And they've done some nice things. They've developed basic and advanced ultrasound or cardiac echo courses. They've developed training centres where neonatal trainees can register with those centres, take part in the courses, do some online learning, and develop a logbook of echoes which are supervised and reviewed by an accredited trainer in their centre. And ultimately, they can get supervisor sign-off, do a short presentation to ASIM, and that provides accreditation. So that's a different model, very much more pragmatic and learning in the workplace approach. Next slide, please. I think perhaps in response to the 2011 statement and developments around the world, we did get a UK statement in 2016, which is now a joint statement between cardiologists and neonatologists. That's a good progression, and the statement is nicely endorsed by BCCA and PECSIG. And if you haven't read it and you are someone who performs echo in your own practice, it's worth looking at because it does provide a nice framework, I think, which would be useful to reflect against in a way of providing your own local governance. However, it's perhaps not quite so useful if you're hoping to train as a trainee or to learn echocardiography as a new skill. Next slide, please. So we looked at this in Glasgow, and we looked at taking the 2016 statement and seeing if we could train someone following their advice in echocardiography. We found that technically it can be delivered, but there were challenges. We summarised these in a paper in 2020, and Dr. Montasser presented it to the BCCA as well. One of the difficulties is, although it recommends a prerequisite echo course, there's no suitable echo course really defined for people training in neonatology functional echocardiography. It still demands 6 months in a paediatric cardiac centre, which we didn't find hugely helpful either ourselves or our cardiologists who have a good working relationship to training someone in neonatal echocardiography. Additionally, it takes 20% of time dedicated to echo, and at present I don't think the colleges and the deaneries have agreed that standard at all and was very difficult to deliver, and it's still very much a time-limited echo production focus course. So can it be delivered in the UK? Yes, it can be, we did it, but there are challenges and it still lacks technical details, a curriculum and guidelines of the type that were demonstrated, that NIM demonstrated the need for. And it still doesn't come with accreditation, so it hasn't solved the UK problem. Next slide, please. However, there are encouraging developments and we all need to think about these. The latest statement from North America, and now notice split off from Europe, is actually now been led by neonatologists who've really developed expertise in this area. And they now define there's very much a neonatal FOCUS and defined TNE as a comprehensive echo to appraise cardiovascular physiology and enhance diagnostic and therapeutic decision-making in the NICU. So it's really moved right away from the cardiology need to focus on structure. Of course, as part of this, you have to be able to define normal structure, recognise it, and continue to work with cardiologists where they're required. But it has moved the focus substantially. Next slide, please. And if you are interested in TNA, I would highly recommend reading the review paper that was published with this guidance. It's a fantastic summary overview of how to perform echo and how to perform functional assessment, both the images required, the techniques required, and the interpretation of them. However, there's no doubt that this position statement still very much looks to full-time training in neonatal echocardiography exclusively in a centre designed to produce this. And there are a few North American centres that can do this, and it may be a very useful approach for some, but it's probably not really going to resolve the UK problem for ensuring that our trainees and neonatologists have the necessary training generally. Next slide, please. Just bringing us back closer to home, the ESPR put together an NPE specialist group. I think recognising that the previous joint North American approach wasn't really applicable in Europe, they published some guidance in 2018, and we can take things from this. They have defined what a training NICU would require and some standards for accredited trainers, and I think we can certainly adopt these in the UK. We have the types of centres and the skill set to do that. They defined an approach to defining structural normality, but haven't really developed the sort of guidance around the sort of pathophysiological problems that we see in the newborn. And it was still very much an intense echo-based programme that they were defining with 200 scans required in 12 months. However, I know from working with the NPE that there's a different approach evolving, and it's worth sharing it. If I could have the next slide, please. So this is a draft document that I've got permission to share, and I think the image in the box there sort of summarises the approach now, that even the ESPR NPE are saying actually for most people work-based learning and competency is more realistic and more achievable than an intensive fellowship per year in echocardiography. They are proposing delivering online educational modules, introductory, basic and advanced echo courses that could be relatively standardised, and a programme of work-based portfolio development and sign off with a locally assigned trainer, all of this sitting underneath the umbrella of the ESPR. But I have to stress, it remains theoretical, nothing is in place yet, and that guidance hasn't yet been published and still requires further work. So in summary, moving on, next slide. I think we really do have to think about what are the future directions in the UK to support people who are currently developing or have developed these skills. And I think the NeoFOCUS-UK SIG group with BAPM really does recognise the need for robust training and governance in NPE. I think we can all now recognise that neonatologists have actually started to set the international standards and develop the guidelines for where the use of NPE is appropriate, and that we're now mature enough as a specialist group to take this forward. There are really, I think, huge opportunities to develop the education, training and governance around NPE in neonatology in the UK. And there's a fantastic opportunity to develop strategy with UK professional bodies, which ones are undecided, or other international organisations to develop a structure for courses, accreditation and training. I think we're delighted to be able to do some of this hand in hand with BAPM, and I think my colleague Neil at the end of today's presentations is going to suggest some ways in which people might want to become involved and share their views on how to take this forward. So thank you.
Thanks, Anne-Marie, for this great talk. And going to hand over to my colleague Anna Milan from St. Thomas.
Perfect, thank you. I think you can see my slides, so I will just start on to talk about something slightly different, which is the role of lung ultrasound in neonatology. So what is lung ultrasound? Well, lung ultrasound is an ultrasound of the chest for the assessment of the pleural and subpleural regions. And if you were to position a probe on the chest of the patient, you will be seeing, first of all, the skin, then the muscles, and then the profile of the ribs. And then you would see a really bright line, which is the pleural line. Everything below the pleural line is actually well-aerated lungs, usually. And because of the physical properties of the ultrasound waves, we will not be able to identify the specific structures in the lungs. We'll not be able to see the alveoli. But what we will be seeing are the lung artifacts. And the interpretation of lung artifacts is what lung ultrasound is based on, which is not a new concept. Lung ultrasound has been around for quite some time, starting in the 60s in adult intensive care, looking at pleural effusions and chest drain insertions. And then from the 90s, Daniel Lichtenstein developed the concept of these artifacts and how to interpret the artifacts to then define the use of lung ultrasound in ICU, which was better determined by his blue protocol, where he describes how to use the different signs and artifacts to understand if the patient was affected by pulmonary edema, pneumothorax, pneumonia. And we've seen the use of lung ultrasound in adult intensive care has expanded, especially around the time of COVID, where we could see a peak of the use of lung ultrasound and publications around it. What was happening at the same time in pediatrics was that initially I spent a good amount of time thinking about how to make sure that we could compare the results of X-ray and CT scans with the results of lung ultrasound. And then gradually from 2015, probably we started to see more PICU units using lung ultrasound in their clinical practice. In neonatology, we somewhat followed the same path. So initially we looked into how to define through ultrasound different characteristics of different conditions that are particularly common in neonatology, like TTN or RDS, or meconium aspiration, congenital pneumonia, pneumothorax. And then from 2015, we moved away from lung ultrasound just for diagnosis, and we used that also for prognosis. So to define, for example, through patterns and scores, to define the degree or severity of a specific condition, and then define set thresholds above which we will be supporting the use of specific treatment. For example, the ERSTE project in 2019 has defined, it was one of the first projects that defined the use of scores to identify which patients affected by RDS would benefit from surfactant. And then we have two of the main publications has been mentioned by my colleagues in the previous presentations already, publication from the ESMIC consensus in 2020, and then the clinical report in 2022, where essentially lung ultrasound officially enters the POCUS use in neonatology. So how do we use lung ultrasounds nowadays in NICU? Well, it can be a real-time diagnostic tool to help us identify the cause of respiratory compromise and optimize the treatment. It can be a prognostic tool to assess the need for admission to intensive care, for example, monitor disease progression and monitor the response to treatment, but can also be a bedside tool to identify the need and to help us guiding specific procedures like chest drain insertions. So today, having only 10 minutes, I will not be able to teach how to use a lung ultrasound. But what I want to for you to see is that actually we can clearly see a difference between what a normal lung might look like and what the lung of a patient affected respiratory condition might look like. So for example, this is just a still image. I know that the majority of you who use lung ultrasound are used to videos, but just to simplify the concept, I'm using a still image of a normal lung of a baby. And we can identify the ribs, for example, in yellow, and the pleural line in blue. And we can see that it looks different from this image of a patient with RDS, where we can equally identify the ribs and the pleural line, but the artifacts that are below the pleural line are totally different. Same things can happen for a consolidation. Again, lung ultrasound can be performed. We can identify the ribs. It's more difficult now to identify the pleural line. It's very irregular underneath the pleural line. So what we see is what we call the shred sign, which is typical of a consolidation. What if it was a pneumothorax? Then again, we will be able to identify the ribs and the top line, which is the pleural line, but then the artifacts below that are different from what we can see in a normal lung. I'm not suggesting that just one still image or one picture will be enough to diagnose a condition. As I said, it's usually a video, but it's also part of a full assessment of the patient. But what we know nowadays is that lung ultrasound is actually more accurate than X-ray for the detection of effusions and pneumothorax, and has a similar sensitivity and specificity to chest X-ray in pneumonia. And this is true based on studies done in adult, pediatric, and neonatal intensive care. We also briefly mentioned the concept of lung ultrasound scores. So again, we're not here to teach about the scores and talk about extensively about it, but just for you to have an idea that lung ultrasound can present with in different ways. It can look different in different conditions, and has this. And we are able to associate these different patterns to different scores. So if we score the different areas of the lungs and then we sum the score of the different areas, we can have a total score of the lungs. And that can give us a level of severity of the condition. And then we can set some threshold above which we will be offering an intervention. And this is something that has been used in neonatology for the past years, because we had now multiple studies and meta-analysis of the topic, talking about how we can define the threshold of severity of RDS, above which we should be offering surfactant. Moving from a more general approach to RDS in general to a more personalized medicine for the management of RDS in preterm neonates. So if we were to think about more in general about the benefits of lung ultrasound, we could say that lung ultrasound is already part of the suggested protocols for the fast assessment of the crashing neonates. One of the examples is the SAFER protocol. Lung ultrasound can help us reach accurate diagnosis, so provide the right treatment at the right time, and help us performing invasive procedures in a safer way. It also helps us reach personalized care. We can, for example, use lung ultrasound to identify which patients are more ready to be extubated, or we can identify which patients are higher risk of evolving to chronic lung disease, and which ones could be more responsive to diuretics, for example. And then it carries some benefits for patients and parents as well. We need to remember that lung ultrasound is a non-invasive procedure. There's no exposure to radiations. There's no need to move the patient to the radiology department, for example, or there's no need to adjust the position of the patient, which is something sometimes we have to do when we are performing an X-ray and we need to position the film underneath the baby. And lung ultrasound can be timed around the patient's needs and can favor parental engagement. Parents can stay at the courtside and talk to us directly while we are performing the lung ultrasound, while often when you're doing an X-ray, you often have to ask the parents to move away or to even leave the room. So in summary, lung ultrasound is a well-known imaging technique. Its role in neonatology has flourished in the past 10, 20 years, supported by the large body of international literature available. It does allow for a physiology-based approach for the patient in line with the concept of personalized medicine. And I think our commitment as NeoFOCUS-UK is to be able to promote a framework for practice for the implementation of lung ultrasound in neonatology. We would love to bridge the gap, promoting standardized training and accreditation programs, which at the moment are lacking in the UK, to match the interest expressed already by professionals working in NICUs. And we would like to support research and QI projects on the topic. Thank you.
Thanks, Anna, for this fantastic talk. And our next speaker, I will present my colleague, Dr. Ahmed Sharjeel from Royal Victoria Hospital. So over to you, Ahmed.
Thank you. So I'm Ahmed, and I will endeavor to address the question why point-of-care ultrasound facilitated central catheter placement needs to be integrated in neonatal practice. So I will endeavor to share experience and evidence as to why this is the way forward. Okay, so the existing practice is X-ray dependent. So whatever comes with ordering an X-ray and making decisions dependent on X-ray comes with activity that we see as a norm, despite the fact that we know what this means is a significant time and effort consumed into making a formal referral, arranging staff and heavy equipment from another department, a lot of baby handling, significant baby handling and radiation exposure, and a key member of the team stuck in scrubs until it's all over. And after all the effort, what you get is a piece of information called X-ray, which is indeed time tested and has been reliable. And in this patient, it demonstrates a line that has been inserted from the left arm, and the tip can be seen in a satisfactory position, except that the ultrasound revealed that the catheter body, the line is in the subclavian artery. It's not at all in the venous system. The X-ray reported by pediatric radiology was as optimal line placement, failing to recognize the arterial cannulation, as was this baby, where the X-ray very nicely demonstrates a line placed from the left leg and the tip sitting in a satisfactory position, except that the ultrasound again reveals that the catheter is pulsating inside the abdominal aorta. X-ray reported by pediatric radiology as optimal line placement, again unsuccessful in identifying an arterial cannulation. Point of care ultrasound has a wider role in less dramatic but more frequently faced situations that we deal day to day in central line insertion. While the X-ray provides information on different structures superimposed on each other on an X-ray film, the ultrasound provides a direct visualization of relevant anatomical landmarks, as you can see here in a line inserted from the lower limb, where the eustachian valve and the junction of the right atrium and the IVC can be seen very clearly to make a decision. It gets even more difficult if the line has been inserted from the upper limbs on a chest X-ray, especially in pathologies where in mediastinum shifting pathologies like the diaphragmatic hernia. Ultrasound, on the other hand, would continue to provide direct visualization of relevant anatomical landmarks and enables the operator to make a reassured, evidence-based decision real time. For an umbilical arterial catheter, it's appalling to say that we are used to ascertain the tip position and level by looking at certain bones behind the vessel. Ultrasound, on the other hand, can demonstrate the catheter pulsating in the vessel itself and all the relevant anatomical structures and landmarks around it. More common situations, the X-ray would not explain, will not provide answer to a question that it may pose all the time. So it does pose a question here. It provides a certain information, but it doesn't really provide the answer that the ultrasound here provides you, that this catheter moves from the right brachiocephalic across the midline to the left brachiocephalic and enables the operator to make an informed decision of whether to use it or not. The X-ray doesn't offer you the option to perform a redirection of catheter tip if and when required. So it does provide you the information that the catheter has gone into the neck as visible here. The ultrasound not just provides the same information, but also enables the operator to pull the catheter back under direct vision into a shoulder vein, a subclavian vein, and then push it back in under direct vision, and enables the operator to see whether it has been successful or otherwise. Ultrasound-guided UVC insertion is a unique advantage that this modality brings in. This UVC is curling up into the liver flesh somewhere. It can be seen here in the ultrasound as well. The advantage the ultrasound gives us here can be seen as the UVC demonstrated here crawls it towards the ductus venosus, and you can see the rest of the UVC entry hitting the inferior vena cava, heading towards the right atrium. A subsequent X-ray, all that this shows is straightening up of the UVC. So at the end of the day, everything boils down to the final tip adjustment. The ultrasound gives a direct visualization, and all it demands the operator to do is to just have a look at the screen, manipulate as necessary, and just do what is required. And you can see, and then once satisfied with the tip position, the line can be fixed without having to go through temporary fixation and getting an X-ray done. In a large neonatal tertiary surgical center audit, 552 long lines were reviewed in 361 babies. Now, about 60% of these long lines needed adjustment after insertion, and therefore a second X-ray had to be done. And a significant proportion, 17% of these, needed more than 2 X-rays and up to even 5 X-rays. And this audit demonstrated a significant radiation burden, which lessened when in a subsequent audit with 187 POCUS assisted line placements, where the reduction in the radiation burden was found to be significant. In another audit here, 92 POCUS assessments for central line positions were performed. Half of them were UVCs, almost half were peripherally inserted long lines, and the management changed following 90% of assessments, and this includes 8 arterial cannulations. In the last decade, there have been worldwide many credible studies and publications, as well as evidence collated, provided, and recommendations made by the POCUS working group of the European Society of Pediatric and Neonatal Intensive Care that support my conclusion for the talk today. That real-time point-of-care ultrasound, of course, in the hands of somebody who knows what they are doing, used for central catheter insertion, reduces number of malpositions and manipulations, reduces radiation exposure, reduces catheter-related complications. Now, our group, NeoFOCUS-UK, is striving to create training package, establish framework, and impart expertise. Thank you very much for your patience.
Thanks, Ahmed, for this excellent talk. And finally, now I'm going to pass the floor to our colleague, Dr. Neil Patel, consultant neonatologist in Royal Hospital for Children in Glasgow. Over to you, Neil.
Thanks very much, Mahmood. Hopefully you can see my slides okay here. It's a pleasure to join you all, and just to briefly, I suppose, bring together all of the discussion that we've had so far. You've hopefully been convinced by the fantastic presentations that you've heard of the role of functional echocardiography, but more broadly, the application of neonatal hemodynamics, and the role of point-of-care ultrasound, including lung ultrasound and ultrasound to confirm line placement, to potentially improve the care and the outcomes for the babies we're looking after. And ultimately, I think that's the driving goal for all of us here. I actually think that this webinar and the activities surrounding it represent a really exciting time and potentially a really important paradigm shift in neonatal care, where we start to really work towards incorporating these benefits that we've been talking about into the routine care of all babies. I think sometimes for people who haven't been involved in applying these tools, or having hands-on experience of them, or even more broadly understanding the concepts. These things can look like a bit of a black box and an unlearnable skill, or a skill that requires a really steep learning curve. But I can reassure you that if I can learn things like this, then anybody can. They are not, my colleagues on here are wonderful people, but they learned just like you learned, and we want to help share that skills and knowledge with other people. And I think there's also an imperative here, and Ahmad's talk just underlined that, because the potential improvement in safety and reduction in risk associated with these skills is going to become really, really important. And in the future, people will ask the questions, including families, as to why we don't apply this skills and knowledge. So the formation of the BAPM special interest group incorporating the existing NeoFOCUS group is really, really timely, I feel. And what I'd just like to share with you is how you can get involved, because what we are really focused on here is collaboration. We want to and be very inclusive and invite other neonatal colleagues, whether you already have these skills or experience, whether you're just interested, whether you're even skeptical, to come and join the group and be part of shaping our future activities and the key areas of focus that we've been talking about: developing training and accreditation, developing frameworks. So let me just tell you a little bit about practically how you can do that. You've heard already what the aims of the group are. You can first of all find out more at the website, which BAPM have very kindly already set up in preparation for this webinar. The URL is there, and you can find out a little bit more about the group and our initial intentions through the terms of references that are posted there. And one of the other things that you'll see there is that we have some nominations open for specific positions within the group's committee, and they are for a trainee representative, a parent or family representative, and for a nursing or ANNP colleague representative as well. And again, you can find details of how to apply for those on the website. There will be future vacancies for other colleagues to join the committees in due course, and they'll be advertised in January 2025. We have an inaugural committee who are going to help to get activities prioritised and started before then. But even if your interest is not necessarily being in a committee member, there's going to be lots of opportunities for you to get involved in the work groups and work programmes as they develop. The other thing is to say that right at this point in time, we're really interested for you to register your interest and to be part of the group. And again, on that web page, you'll find at the bottom of it this very brief web form. Just give us your name and your email address, and that will make sure that you get onto our mailing list for our newsletter and for all the upcoming communications from the group. So please go there and add that in. Finally, and just in the spirit of the group, which is very much based on understanding current practice and current views, not just of people who are performing POCUS and neonatal hemodynamics, but the broader community, everybody in the neonatal community. We really want to gather your thoughts and opinions at this time, and we've developed a short survey to do that. You can access it through this QR code here and the URL, and hopefully with the help of BAPM, we can also share it through their channels as well. The survey will branch depending on whether you identify yourself as someone who's experienced in neonatal hemodynamics, or if you're someone who's not. And we want to gather, both of your opinions are equally important to us, and they'll help us shape the prioritized activities of the group and our future activities. So please, if you have a few minutes, link to that survey. It's really quite short and shouldn't take you more than a few minutes. So I'm going to stop sharing my screen there. And just once again, thank you very much for your time, for joining us this afternoon. We hope that we've engaged you in why this is such an important step in forming a special interest group within BAPM. The one thing I think that we need to move forward with, as well as collaboration, is humility. And the reason I mention that, and it's a quality that all of my colleagues share, is that those of us who perhaps have developed some experience in this field are humble to want to share that and to help colleagues to develop it. And perhaps those of you who might have been skeptical or not sure about the role of this, and we would ask you to keep your mind open, and hopefully some of the evidence we've shared with you today will encourage you to want to get involved and to learn more. So thanks very much for your time, and we really, really look forward to you joining the group and joining us on this journey.
Can I say a few words, Neil? Just from
Yes, of course, Cheryl. Yeah.
Hi, sorry I'm late, I'm on call, but I just wanted to come and just show our support from the BAPM, and that we're really excited that we're going to have an affiliated special interest group, and that we'll have a hemodynamics theme as well at this year's BAPM conference. So please do register, and we've got great speakers lined up, including Neil. Okay, thanks.
Thanks, Cheryl, and would like to also thank all our colleagues from BAPM for their great support. Now we'll open the floor for questions, so please feel free to turn on your camera and ask directly the question. I'm trying to pick up the question on the chat box as well, and I will direct it to relevant colleagues. So I've got some question, if I may start with, and I will direct it to you, Nim. It's from our colleague Beverly. We all know Beverly from Bristol. I've attended your course, Beverly, over 10 years ago. It was a fantastic course. So she's asking about us as a neonatologist. How can we ensure we're not missing major congenital heart disease that can produce similar symptoms for pulmonary hypertension, for example?
Yes, thank you, Beverly, and hello again after many years. It's a very valid question, and something certainly from a paediatric cardiology perspective, people will be concerned about. I think this is a personal view rather than a collective view. I think we do need to understand our limitations, first of all, as neonatal echocardiographers. And I think a basic understanding of congenital heart disease and structural heart disease is essential. Rather than focus on a definitive diagnosis of a congenital heart defect, I prefer, certainly when I'm doing a scan and teaching others to do scans, to identify red flags, things that seem unusual. So I see our role as screening for congenital heart disease, not in the strict sense of the word screening, but to just do a structural echocardiogram. And if there are features that are unusual, to help guide us in terms of how quickly we need specialist paediatric cardiology input into that case. And I think that's key, understanding what the warning signs are, where things aren't typical, where there are things that we don't understand and can't explain. Those are sorts of things that help us identify which babies we should be referring urgently for paediatric cardiology and a definitive structural echocardiogram. But we must remember that without any sort of echocardiogram, we are treating completely blindly. We're treating babies as if they've got PPHN without even recognizing that they may have an underlying structural heart defect. So I hear very loudly and clearly those concerns about missing an underlying structural heart defect. And yes, there is a risk, but people should be going into this with their eyes wide open and understanding the limitations.
Perfect, thank you. Can see some hands up, so please go ahead with your question.
Oh, hi. Excellent. Thank you. And brilliant initiative. I'm Anju. I work at Birmingham Women's and Children's Hospital and part of the West Midlands network. And we've done a lot of work in the West Midlands around POCUS. And I guess the question which follows on is from what Beverly's just said, is to be very clear around the governance and being very clear about what am I doing the echo for, and in terms of documentation, like if I'm asked to do, I write very clearly, I'm doing a targeted echo looking for this. And this is essentially an ultrasound stethoscope, which is adding to the clinical information, and not to forget the clinical acumen kind of overrides, if you're not sure about your echocardiography skills. So I think the clarity of documentation is very important, and part of this group would also be being mindful of the governance around all this.
Thanks, Anju. I see Mohammed and then Wissam.
Hi guys, it's Mo here, Oro Park. Thanks actually for the excellent presentation. I have a reservation about the term neonatologist performed echocardiography, and I think the term first because if it implies that's only be done by neonatologists, and I'm someone who has been trained and precepted by advanced nurse practitioner who actually is doing TNE. So, and I'm glad that actually it's part of the committee. There is a spot for nurse practitioners. So I think that will be of great importance to widen the scope of how many people can do it. And I don't like the term echocardiography because the targeted bit of it is basically what we're looking for. I mean, at the end of the day, we're not cardiologists. Any program need to have the support of the cardiology team as part of the the development of the program or even the accreditation. And I think we shouldn't think about the program as a standalone, but in cooperation with our colleagues in cardiology. I think in the past, especially the development of it in North America, was about billing because it is pay per service. So whoever does the imaging get to bill for it, and this was the friction. But I think they have reached a great deal for it. The other question is just what do you do in terms of units where you still find the location, the tip of the central catheter access, and still you find the practice, there is a need for an X-ray to confirm it. How do you going to change that attitude? And thank you very much.
Thanks, Mo. Anne-Marie, would you like to answer the first part, and then Ahmed will follow on?
Hi there. I think they're really good points. I have to say, I think the nomenclature around this, whether it's NPE or TNE, neither of them are ideal. NPA seems to have been adopted in Europe, TNE in North America. It's not really targeted. It's a very wide-reaching, looking at the whole structural scan before you do anything else as a baseline, and really quite complicated functional assessment. So I don't think either of them are great terms, but we're maybe a little bit stuck with them just now, but it's something the group can think about. I'm very conscious you say other people can do this. It doesn't necessarily have to be led by neonatologists. And actually the North American guidance is clear about that as well. It's about having the right knowledge and the right skills, and different groups might be able to take this on. And that's, again, something we really need to consider in our guidance, though there's a lot of, I think, interest in making sure that we provide a structure for neonatal trainees. So that's the main thing about scanning. And the other thing is to say, absolutely, you do have to work in conjunction with pediatric cardiologists and let them know we're doing this. We do that very much in our own centre, but we're also very aware that they see themselves as providing a very different service and resource, and they don't want to be there several times a day or in the middle of the night looking at a baby whose heart is functionally not perfect, but doesn't fit their remit of congenital heart disease and is a very specific response to perhaps prematurity or another common neonatal condition. So we need to keep all of those things in mind and very much keep our links open, but I don't think cardiology want to drive this and don't want to in North America, is my current impression. I think the next bit of the question was about line placement, is that right?
Yeah, thanks, Anne-Marie. Ahmed, I think the question was, are you suggesting that POCUS for tip position is going to replace X-ray? My short answer is no, but I will let you answer that.
Well, my short answer is yes. I think, Mo, you kind of answered the question. There's this issue with mindset. And a very common, relevant example here would be that you can see the line tip in relation to the IVC RA junction and the Eustachian valve, and yet somebody would say what thoracic or lumbar level that really is. So a lot of issue with mindset, as Neil said, the paradigm is shifting, but it needs to shift. For lines, I see no excuse for not doing it real time because it's invasive. Unlike the rest of the point of care scans, you're not putting a needle in. Everything else can be corrected by somebody senior who can come in. But when you're telling parents that I'm putting a line that will go all the way close to the baby's heart. There's no reason why you would be doing this blindly when you can afford to have the ultrasound. So I think gradual at the moment, yes, Mahmood, you're right, it hasn't replaced, but this is the way forward with technology improving, with ultrasound machines as well, the size and the resolution. I think there'll be, and at the moment, yes, there are many occasions when I know myself and some of my colleagues who would not do an X-ray at all, not even the first one. Yeah, so I think it's the mindset thing. You kind of answered the question yourself partly. Thank you.
Thanks, Ahmed. It's just probably until the team is very comfortable in using POCUS, probably we just to have some governance about that, just to keep the X-ray as another confirmatory way, and then we'll take it from there. Many hands I can see. So next one is Wissam and Beverly again after, and Professor Sigal.
But actually, this is and everyone is very good presentation. Actually, I attended the same course of Beverly years ago with yourself, and that just tells that I'm getting older, really, in that regard. I have actually two questions. One is directed towards and I'm glad that we regard to the echo or POCUS echocardiography that we are doing as a neonatology. My a question is more or less, yes, in our center, like here in Plymouth, we have a cooperation with Bristol's and Southampton Cardiology, and they are core of it. But I agree, we need to have, because some of the children, we all know, they come in, you will have 4 or 5 echoes done within 24 hours, and cardiologists cannot deliver the service. My question is, how flexible the program that we are looking for? Because if we need to be robust and flexible at the same time for the program that we are planning in. For example, is not every unit has an access to cardiology in the same hospital, but probably they have a remote cardiology access that they could help in these kind of echoes. So I just wanted to understand the way as a group, our thinking, what we are thinking, what's the program or the training, or are we at this stage yet? And in regard to Ahmed, is actually, I'm glad that we are talking about central line insertion and ultrasound. My worry is the medical legal aspect of it. So if we are at what stage we will say, okay, we are 100%, we can say through the ultrasound that this type of line at this level, and we are happy with it. Because my experience, some of the lines I need to use contrast, like injecting normal saline, for example, just to see if this is basically satisfactory. So I just really want to understand your experiences in regard to the medical legal aspect of it. Thank you.
Thanks, Wissam. So Anne-Marie, would you like to comment?
Yeah, I think, you know, it'll be really important for us, I think, to have people from local neonatal units, non-tertiary centres, I think, involved in this group to think about actually what sort of babies might we want to look at NPE in or echocardiography in, and what are the indications and how we help support them around that. I do think, though, for any centre that's going to start taking this on, you do need to think about your local governance links and links with cardiology. And something I didn't share just because I was really aiming to do a 10-minute talk is actually the structured guidance that came from the 2016 statement about having that, about storing your images, about doing formal reports and standardisation of them. These are things we absolutely have to adopt and do properly and carefully. But I think for any group taking this on, they do need to work out with their local cardiologists how it's going to work. Are they going to be happy to phone them in the middle of the night and say, I've done this echo and I'm not quite sure if it's showing me this or that, and really very much keep in mind those clinical parameters that would make you refer to cardiology. But yeah, definitely work to do with local, smaller, non-tertiary quaternary units. Thanks.
Thanks, Anne-Marie. Beverly, sorry, your hand's been up for a while. Want to come in? Sorry, you're muted.
Can you hear me now? Great. I mean, first of all, great to see so many friends that I have taught over coming up to almost 30 years. So it makes me really, really old. Obviously, being a pediatric and fetal cardiologist, I'm a converted person already to a certain degree, but obviously I always got these red flags in the background, and knowing the pitfalls that after how many 30, 40 years as a cardiologist, you only pick up due to experience on a day-to-day basis. So trying to screen for congenital heart disease with little or limited training, I just want to be caution that thinking. And I think, as many people have alluded to, I think close collaboration with cardiology or cardiologists is really important. I also alluded to in the chat that perhaps the EACVI exam would be a useful baseline, because it's a very standardized exam that people can sit, and actually we endorse that for our trainees. So if it's good enough for our trainees, I think it'd be good enough for neonatologists. So that would be perhaps the starting point that you could start. And then I also thought, and you may have already thought of that, having perhaps a pilot study or a unit where you can have a close collaborative working to establish some form of training, formal training with a cardiologist. I know that I'm actually moved from Bristol. I'm now at the Brompton. I'm in London, working perhaps with the St George's team or any other teams that you can perhaps formalize more training program with some trainees coming through, and then compare and contrast. But that probably be baby steps, but we can potentially mimic some of the training that has already been trialed and tested in America and Australia, and then just apply that here. Obviously, the accreditation seems to be a bit of a sticking point, because my colleagues are probably not that convinced, but equally, we're equally not keen to get up at 3 o'clock in the morning because you've got a large duct and you need hemodynamic assessment. And you're probably correct, as a cardiologist, we're more interested in structural assessment, but obviously some of the functional assessment do play into the role of some of the cardiologists. But that's what I wanted to say. So nice to meet everybody.
Thanks, Beverly. And our plans is to collaborate with our colleagues from cardiology and our other specialties as well. If we're going to produce any kind of frameworks, national frameworks, that has to be in collaboration with our colleagues from different specialties. Absolutely. Arvind?
Thank you. Hello, Neil. Fantastic to hear from the UK group that we are heading towards, some framework towards training, learning, governance. Just wanted to share some experience from Australia, because, the Australian system has led the way for many, many years. There is always a learning curve, and definitely a supportive cardiologist locally is going to be very helpful. A few things which hadn't been discussed, I thought I'll just point out. When a written report is essential, you've done an echo, there has to be documentation. And since 2007, our first line of that echo report is that this is not an anatomy scan. If it has been done by a cardiologist, fantastic. If not, then the medical team must organize that. Now, that organization of the anatomy scan doesn't have to be the same day. Could be 2 days later, could be a few weeks later. But before the baby is discharged home, that baby who has been assessed by a functional echocardiography scan must get an anatomy scan. So that's our arrangement with cardiology. Over time, when the confidence within the cardiology team towards the neonatal team has increased, then many a times they look at our scans and they say, okay, we don't need to do another scan on this baby. We are very happy that you have all the information which we would be happy to sign up to say anatomy is normal. Second thing which I thought which hasn't been discussed is archiving your images. Many units around Australia, they archive on the machine. Some don't archive at all. So if there are no pictures to be reviewed later on, then it's always, he said, she said, I saw this, I didn't saw that. What we work as a Monash model is all scans done by the neonatologist are archived in the same hard drive as the cardiologist. So if, for example, a long-term stay has had 3 scans done by me and 4 by cardiology, if you write the baby's medical record number, all 7 scans will turn up in sequence. The only difference is our scans are reported by us, their scans are reported by them. But there is an opportunity available to join all the 7 dots together at one moment to say how the things evolved over a period of time, which is essential for things like BPD, pulmonary hypertension, or infant of nitric oxide, or hypotension, and all the indications which Nim was mentioning. So I think archiving is an important part of governance, and again, a collaborative model with cardiology is the way to go. Thank you.
Thanks, Arvind, for sharing your experience from Australia. I'm just conscious of time, so we've got a few hands left. So maybe we'll just take a couple of more questions. So Tosin?
Chelsea. We have had a third reduction in the use of X-rays in the last year, just from POCUS alone, and this has been safely managed. I think in terms of process, we focused on lines and lungs first, and we've left hearts to 3 consultants, 2 of whom are PECs, and 1 of whom is a neonatal interest in cardiology. And we do have fortnightly review meetings internally, and we have a low threshold to involve our cardiologists when they visit us, or IEP images to them. So I think these things can be done in a staged process. Not everyone needs to be doing cardiac hemodynamics. And I noticed from the discussions that the focus and the concerns have been largely from the heart point of view, less so from the lungs and lines. And I can understand that because of margins for error in particular. I wanted to ask that with this group, I think also focusing on things like neonatal transport teams. And I used to head the transport service, and I certainly appreciate the value in shortening turnaround times, being able to not waiting around for X-rays for line positions by transport teams, being able to get more real-time information about lungs so that they can fine-tune management better. And I would also propose that transport teams should be sort of put forward in various settings to learn these skills perhaps in advance of others, because I think there's far more, perhaps a little bit more utilization in those roles as opposed to being on the units. I also wanted to talk about database. Badgernet, for instance, you can't still put on a report on Badgernet for line assessment. It comes up with lots of things, and we usually have to report it under ultrasound, thorax, or echo. But we need to leverage these organizations as well that we all largely use, so that they now create compartments whereby we can document line assessments properly. For medical legal reasons, clinical purposes, as well as for audit purposes. I think we, having this organization, having this body, allows us to leverage them to say they do need to redesign or accommodate POCUS in their databases. And I look forward to this team being able to push that forward.
Thanks, Tosin. That's brilliant. We'll have Steve, then Cheryl, and I think I will just have to stop after that.
Thanks very much for a very interesting meeting. I've been a long-standing enthusiast for hemodynamic assessment of neonates, and I've tried to train lots of people in doing it. There are differences in aptitude between individual trainees and fully trained neonatologists, and I think we just have to be aware of that. I think probably nearly everybody could be trained to recognise a poorly filled and a poorly contracting ventricle. That's probably, I think, something we could get everyone to be able to do. But we need to make sure that if we're offering training, we allow people to recognise if they have necessary aptitude to be able to do a full assessment, or whether they can just do a first-line assessment and they need to use that famous test of call a friend and to call in somebody who's got greater expertise. And if we can make sure that we do that in a way where we're not making people feel bad that perhaps they've not got the ability to do a full functional or structural echocardiogram, that actually calling a friend is fine to do. We build up a body of people with appropriate expertise so that those people are available, not just during the day, but also at night, and can be called in if necessary. So if I hope some of you will agree that that perhaps there are differences in aptitude, and we've got to be able to work that into our workforce planning and the way in which we deliver and recognise training.
Brilliant, thank you so much. Cheryl, if you want to come in.
Yeah, just really quickly, I know you're running out of time, but I just wanted to say that we are going to be co-producing a framework, a national framework. As we know, I'll be co-chairing this with the NeoFOCUS group, really focusing on promoting the safe and effective use of cardiac ultrasound or echocardiography. It really, so that we can have the confidence that we can incorporate that into routine neonatal care, as Nim so eloquently points out how important that is. And there are two aspects there. There is the first aspect in terms of the safe use, so the clinical governance surrounding it, and really good discussion. These are the things we really need to put in the framework of what we think would be best principle, and really useful input from Australian teams, and the important close working with the cardiologist and how that service may look different in different places, but there are best principles to be applied. But the second thing that we've also touched upon is the competencies. And Bev, I've learned from you, it's really nice to see you, lots of years of you expanding your knowledge and really circulating that among the neonatal community. But actually doing an EACVI exam requires 250 echoes. It's not practical for everyone to get these competencies. Certainly in the Progress Plus, the CSAC will, there aren't those opportunities to all be located in the cardiac job, for example. And so I think the idea that Steve also suggested is, we need to recognize at different levels of competencies, level 1, 2, 3, and we should have some formal way to recognize that. Otherwise, the current landscape is that everyone says they can echo or do cardiac ultrasound scan, where they may be able to, but we can't tell someone who's done 200 echoes compared to someone who's done like less than 10. So I think these are the sort of things we would like to include in our framework going forwards together. Just want to say thank you.
Thanks, Cheryl, and thanks everyone for joining. It's a great pleasure to see so many colleagues joined us today. We'll be in touch with you through BAPM channels and newsletters. We'll announce for further activities and courses. And as I put in the chat box, hopefully we'll host a conference sometime at the end of the year, around September or so. We'll announce officially about that, hopefully in the next few weeks. So thanks everyone for joining, and thanks for the speakers for your time, and have a great afternoon, everyone.